I want to give some updates regarding pulmonary hypertension, and I strongly recommend that you review my prior talk on pulmonary hypertension, hemodynamics, and tips and tricks. For this talk, I will give at the end reminder and updates regarding the three hemodynamic types of pH, namely the postcapillary pH, the precapillary pH, and the combined pre- and postcapillary pH. But before that, I would rather concentrate on the more advanced update to that diagnostic hemodynamic approach. I want to specifically focus on three instances where vasodilator therapy may be considered in combined pre- and postcapillary pH. First, I want to give you some reminders. Let's remember this. Can you have postcapillary pH with elevated PA pressure yet normal PC wedge pressure during right heart cath? So let's take this patient with precapillary pH, wedge pressure less than 15, and PVR over 3 Wood units. That seems like PAH, precapillary pH. Yet, it's possible that this patient has combined the pre- and postcapillary pH, and he has been well diuresed in so much that the resting PCOH pressure is now normal, but the PA pressure is still elevated as the improvement of PA pressure lags behind wedge pressure in patients with combined pre- and postcapillary pH. Wedge pressure may become normal while PA pressure is still elevated, mimicking precapillary pH. And in those patients, PVR is usually only mildly increased, meaning between 2 to 5 Wood units. So when you have combined pre- and postcapillary pH, the PA pressure rises disproportionately to the wedge pressure because you get some arterial constriction and arterial remodeling. And after the wedge pressure normalizes, that arterial constriction and remodeling will improve almost always, and PA pressure will almost always dramatically improve and will often normalize. Even in patients with severe mitral stenosis and severe combined pre-postcapillary pH from mitral stenosis, their PA pressure typically normalizes eventually if you fix the mitral valve. However, it takes some time. And those are the patients who may be considered precapillary while in fact they are combined pre-postcapillary pH. And when should you think of that? In any patient with a precapillary pulmonary hypertension on right heart cath, who also has diastolic heart failure risk factor, particularly if the wedge pressure is also between 13 and 15, you should consider a stress maneuver during right heart cath. What are those diastolic heart failure risk factors? You have clinical risk factors, mainly the top four, which are obesity, severe hypertension on multiple medication, especially if uncontrolled, age more than 65, especially more than 75, and atrial fibrillation. So those are the four big clinical risk factors. You also have the four big echocardiographic risk factors, such as low E prime, high E to E prime, significant, especially severe left atrial enlargement, and severe left ventricular hypertrophy. So if you have a combination of those clinical and echocardiographic risk factors, you should consider exercise or volume loading in any patient with what seems to be precapillary pH. And if wedge pressure rises excessively, then you should consider this patient to have combined pre- and postcapillary pH with a masked postcapillary component. And those are the maneuvers we perform. We do exercise testing with supine cycling in the cath lab. And if wedge pressure, mean wedge pressure rises to 25 or more, this implies left heart failure. And we use a cutoff 25 instead of 15, as wedge pressure normally rises in normal individuals with exercise, especially extreme exercise. And you may see on this pressure volume relationship between preload and wedge pressure that even normal individuals, if you raise their preload enough with high output states, they will get some rise in wedge pressure. In younger individuals, you may get a rise in wedge pressure of 15 to 20 millimeter of mercury. In older patients over the age of 50 with some impairment of the stiffness of that curve, you may get further rise to 25 millimeter of mercury. You may also do vasodilator challenge or passive leg raising or saline loading of 500 milliliter in 10 to 15 minutes. And with those maneuvers, a rise of wedge pressure to 19 or more is consistent with left heart failure. But what I like more than just those numbers, I like to use the pressure volume relationship, which you can apply easily during right heart cath. The pressure volume relationship correlates with wedge pressure cardiac output relationship. So I like to do those maneuvers and measure how the wedge pressure as well as the cardiac output changes during those maneuvers. And the delta wedge pressure divided by delta cardiac output of more than 2 correlates with that diastolic heart failure. It really implies that you have that steep relationship of diastolic heart failure. Also, on your baseline hemodynamics, even if your mean wedge pressure is normal, as in this case, where it is around 14-15, look at the morphology. If you have pronounced V wave or a pronounced A wave, either one of those, that's a hint to left heart failure, and those are the patients in whom you should further consider stress maneuvers. Take, for example, this patient with a mean wedge pressure of 14-15 but a marked V wave. We performed just passive leg raising on him, and you can see that the mean wedge pressure rose easily to close to 25 millimeter of mercury, and the V wave rose furthermore, which established the diagnosis of left HFpEF in this patient and combined pre-post-capillary PH. Now I will move on to answer that question. Can patients with combined pre- and post-capillary PH be treated with pulmonary vasodilators? The simple guideline answer is no, including the latest ESC guidelines from 2022. PH must be purely precapillary to qualify for pulmonary vasodilators. However, there are 3 instances of combined pre- and post-capillary PH where pulmonary vasodilator therapy may be considered in agreement with ESC guidelines. And I will elaborate on those 3 instances. But before, here are the trials that argue against pulmonary vasodilator therapy in left heart failure. There are several trials that show that pulmonary vasodilator therapy is harmful in left heart failure with reduced EF. The problem is that all of those trials were heart failure trials. They took heart failure with reduced EF population with disregard to pH or to the presence of precapillary pH. So those were heart failure, not pH trial. Now regarding heart failure with preserved EF, same thing. We have 2 trials of sildenafil in heart failure with preserved EF, including heart failure with preserved EF and some pulmonary hypertension, predominantly post-capillary pulmonary hypertension. And those trials, including one of them is called RELAX trial, have not shown any beneficial effect of sildenafil on symptoms, peak O2 consumption or exercise capacity or hemodynamics, even in patients with impaired RVPA coupling. Similarly, sildenafil has not proven beneficial in patients with corrected valvular heart disease and residual pulmonary hypertension. In fact, it worsens outcomes in those patients. Same in 2 small studies of bosentan and macitentan in heart failure with preserved VF and combined pre- and post-capillary PH. However, none of the prior trials focused on severe precapillary PH. In fact, in combined pre- and post-capillary PH with severe PVR elevation as indicated by PVR over 5 Wood units, yet only mild wedge pressure rise of 15 to 20 millimeter of mercury, and a predominant right heart failure clinical picture, the so-called RV phenotype of heart failure with preserved VF. So only mild wedge pressure elevation, severe PVR elevation, and severe predominant right heart failure. In those patients, sildenafil may be considered according to just 1 trial by Ghazi et al. And 2 retrospective analyses. This study by Ghazi et al. Was published in 2011 in Circulation, but unfortunately there are no other randomized trial addressing this issue. And while this pulmonary vasodilator has a questionable value in this context, the 2022 ESC guidelines do not contraindicate PDE5 inhibitors in combined postcapillary and severe precapillary PH with PVR more than 5 Wood units and severe RV failure, and recommend individualizing the approach to treatment. And this is from ESC. It is recommended that patients with combined pre and postcapillary PH and PVR over 5 Wood units and or predominant right-sided heart failure receive individualized decision making. And they mention it again here in the text. Again, they insist on PVR more than 5 Wood units to consider PDE5 therapy in those patients whose wedge pressure is not severely elevated, again in that 15 to 20 range. So those are the three scenarios where I think pulmonary vasodilator therapy may be considered in combined pre and postcapillary PH in compliance with ESC guidelines. One, combined pre-postcapillary PH with only mild wedge pressure rise of 15 but severe PVR more than 5 and predominant RV failure, the so-called RV phenotype of HFpEF. Now, the second case scenario where pulmonary vasodilator therapy may be considered in combined precapillary postcapillary PH are those patients who on the initial study have wedge pressure over 15 but severe PVR elevation. You treat their left heart disease, you diurese them, and now the wedge pressure is less than 15 on repeat right heart cath, but the PVR is still over 5 Wood units. Those are the patients in whom you may consider pulmonary vasodilator therapy. And the third scenario where pulmonary vasodilator therapy is considered is in patients with PH and normal resting wedge pressure who nonetheless have HFpEF features and abnormal wedge pressure with exercise or fluid challenge or vasodilator challenge. Those are the patients I described a little bit earlier. So patients with normal resting wedge but only abnormal stress wedge may be considered for pulmonary vasodilator therapy. In fact, exercise testing for normal resting wedge pressure is only given in class 2B in ESC guidelines. And in all those three instances where pulmonary vasodilator are considered in combined PH, you start vasodilator therapy slowly as monotherapy and with close monitoring. That's why the ESC gave a class 2A for vasodilator monotherapy in PAH with left heart phenotype, specifically that number 3 here. Those patients are considered to have a combination of WHO type 1 and WHO type 2 PH, meaning idiopathic PAH with postcapillary PH. They have a worse prognosis than isolated precapillary PH and a lower tolerance of vasodilator therapy. That's why we start one with close monitoring. They may also be patients with pure WHO group 2 PH, but who had that left heart disease for too long and their wedge pressure was elevated too much for a long period of time. And even though they are now in better left heart condition, their PVR is now severely elevated and will lag significantly behind the improvement of wedge pressure. Those are some of the references. So here is my updated algorithm. If you have somebody with seemingly a precapillary PH, but he has diastolic risk factors and you do exercise or volume loading and wedge pressure rises significantly, then you diagnose them with combined pre and postcapillary PH. Yet you would still consider vasodilator therapy in those patients if PVR is more than 5 Wood units and you start it as monotherapy. Those are what we call PAH with left heart phenotype. You may not even do exercise or volume loading in those patients. Whenever you have a precapillary PAH with diastolic heart failure risk factors, including older age or many diastology features on echo or AFib, in those patients start monotherapy. You suspect PAH with left heart phenotype. Even if their pulmonary hypertension is purely precapillary, they likely have some underlying left heart diastolic dysfunction. And if you dilate the pulmonary circulation and abruptly increase the preload of that left heart, you will potentially develop pulmonary edema and a rise in left heart filling pressures. Now, the second scenario where you would consider vasodilator therapy is those patients with combined pre and post-capillary pH, wedge over 15 and PVR over 3, but whose PVR is severely elevated, 5 Wood units, with only mild wedge pressure elevation of 15 to 20. The third scenario is those patients whose PVR is severely elevated over 5 Wood units and wedge pressure eventually declines to less than 15 with diuresis and left heart therapy upon repeat right heart cath. And in those two scenarios, it is important to ensure that those patients will tolerate vasodilator therapy by one, starting vasodilator therapy as monotherapy, and two, do vasodilator challenge in the cath lab and see whether their wedge pressure will rise with vasodilator challenge in the cath lab or whether they will become hypotensive or hypoxic in the cath lab. People think that vasodilator challenge is done to see whether PA pressure declines with vasodilator, but more importantly, it is done to gauge the eventual tolerance to vasodilator therapy, including the tolerance of the left heart to that vasodilator therapy. And by the way, another entity where ESC guidelines recommend vasodilator monotherapy as a start is those patients with PAH and cardiopulmonary phenotype, meaning those patients with severe PVR elevation who also have significant lung disease. We know that significant lung disease, even if severe, should not cause by itself severe PAH. So whenever you have severe PAH with severe lung disease, we consider PAH a primary process, possibly aggravated by lung disease, but not caused by lung disease. And severe PAH is defined by the SC guidelines, including in those patients, as PVR over 5 Wood units, or you may also use mean PA pressure over 35-40 millimeter of mercury, or systolic PA pressure over 60-70 millimeter of mercury. So those patients, we treat them with pulmonary vasodilator therapy. However, keep in mind that pulmonary vasodilators may aggravate VQ mismatch in those patients and aggravate hypoxia. That's why you may consider in those patients inhaled pulmonary vasodilators, and those are approved for use specifically in pulmonary fibrosis with PAH. And those inhaled pulmonary vasodilators, they go specifically to the areas that are well ventilated. Therefore, they vasodilate the circulation of the lung areas that are well ventilated. So they will not worsen VQ mismatch. But anyway, those patients may be treated with any pulmonary vasodilator therapy as long as PAH is severe. The important thing is start with monotherapy in those patients with PAH and pulmonary phenotype. Now I want to give you my updated treatment algorithm for PAH, which is in agreement with the ESC guidelines. But before, remember that there are three major classes of drugs for PAH. Number one, you have prostacyclin, which comes in IV, sub-Q, or inhaled forms. You also have that within that category, the selexipag, an oral prostacyclin receptor agonist. You have number two, the endothelin receptor antagonist, and number three, the PDE5 inhibitors. Close to number three, you have another class called riociguat, which also works on the CGME pathway. It is less often used and should not be combined with PDE5 inhibitors. Before you start treating the patient, besides considering the left HFpEF phenotype and considering the cardiopulmonary comorbidities, classify the patient into categories of risk, low, intermediate, or high. And that classification depends on the clinical features, mainly NYHA class, 6-minute walking distance, but also physical signs of right heart failure. We also consider BNP, echocardiography, and invasive hemodynamics. When we treat patients, we want all intermediate and high risk to become low risk upon treatment. And what we mean by low risk is NYHA class 1 or 2, very good 6-minute walking distance, NT-BNP less than 300, reduce RA area, RV volume, and RA pressure by IVC assessment. And on invasive hemodynamic, it's not the PA pressure that we look at, it's mainly the RA pressure, the cardiac output, and the mixed venous O2. Over 65% is low risk. And when we treat patients, we look at an improvement of those risk criteria. We don't always repeat right heart cath after the baseline. We do consider repeating it after 3 to 6 months of therapy in patients whose baseline risk was high in that threat category, or those patients who are not becoming low risk by other measures. And this is the treatment algorithm whenever you have that left heart failure phenotype, or when you have cardiopulmonary comorbidities, we typically start initial monotherapy with PDE5 or ERA. For most patients, we start double therapy because most patients fall into that low or intermediate PAH, low or intermediate risk PAH profile, and we give them double therapy, typically PDE5 plus ERA. If they do not achieve a sustained response into low risk, then we upgrade to triple therapy, typically with the addition of some sort of prostacyclin. Now, for high-risk patients, including NYHA class 4 or other high-risk feature, we start triple therapy, which includes in those patients definitely an IV or sub-Q prostacyclin. And keep in mind that there is a new fourth major type of PAH therapy called sotatercept, which is a sub-Q drug. This one doesn't directly vasodilate the pulmonary artery. It inhibits the TGF pathway and reduces arterial wall growth and promotes reverse remodeling. And this therapy has improved outcomes when added to double or triple therapy in all risk patients, low to high risk, and should be considered early on in these patients. Now I want to give reminders and updates on the definition and hemodynamic subtypes of pulmonary hypertension. It used to be that pH is defined as mean PA 25 millimeter of mercury or more, but ESC guidelines now uses a cutoff of 21 millimeter of mercury. I still think 21 to 24 is a gray zone. They use this cutoff based on prognostic long-term data. Now, pH is subdivided into three hemodynamic groups: the pure precapillary pH, the pure postcapillary pH, and the combined pre and postcapillary pH. The single most important feature to look at is wedge pressure. 15 or less is consistent with precapillary pH. Over 15 is consistent with the postcapillary component of pH, but that postcapillary pH may also be combined pre and postcapillary pH depending on the PVR. Okay, so precapillary pH is defined as wedge pressure of 15 or less and PVR of 3 Wood units or more, but now the ESC uses a cutoff of 2. Yes, indeed, it is true physiologically the normal PVR is less than 2 Wood units, not 3. And prognostic population data have shown that a PVR of over 2 correlates with impaired outcomes. However, I still like to use the cutoff of 3 because, like anything in medicine, it's about the balance between sensitivity and specificity, especially for a measure that implies equations and calculations where you can have errors. So PVR more than 3 is the more specific cutoff. PVR over 2 is the more sensitive cutoff. You will have some patients with PVR between 2 and 3 who are normal if everything else is normal. If their PA pressure is normal and their wedge pressure is less than 15 and PVR is between 2 and 3, then PVR is probably normal in those. Another thing is in precapillary pH, you have what we call a diastolic pressure gradient, DPG, meaning the PA diastolic pressure is higher than the diastolic wedge pressure by 7 millimeter or more. Okay, because those pulmonary arteries are remodeled and constricted. So there is an uphill between the wedge pressure and the PA diastolic pressure. Whereas in postcapillary pH, that gradient is less than 7. However, the ESC guidelines recommend against using that diastolic pressure gradient. The reason for that is that we often miscalculate the diastolic pressure gradient. The true DPG is diastolic PA minus diastolic watch pressure, whereas it is commonly miscalculated as diastolic PA minus mean watch pressure. So the diastolic pressure gradient is the gradient between diastolic PA pressure and diastolic watch pressure, but it's often calculated at diastolic PA pressure minus mean watch pressure. So if you take the patient with a high V wave, their mean watch pressure will be much higher than the diastolic watch pressure. And in that case, that calculation will be falsely reduced. So your diastolic PA minus mean watch pressure will be low, will be falsely low, and you'll end up missing a precapillary component of that pH. This is particularly the case in those prolonged and severe left heart failure. They have big V wave and a high mean wedge that makes you underestimate the DPG, and they have a low cardiac output, so their PVR is high. This is the equation for PVR. Their PVR is high. As the low cardiac output, the low denominator in that PVR equation, making it easy to have high PVR. But their DPG is low. That's why we go by PVR, but DPG, if properly calculated, may be used in my opinion. And here, remember, the PVR equation uses the difference between mean PA pressure and mean PC wedge pressure, whereas the DPG gradient uses the difference between diastolic PA pressure and diastolic wedge pressure. And this is the definition of combined pre- and post-capillary pH. So you have a wedge pressure over 15, hence the post-capillary component, but the PVR is 3 or more, and the diastolic pressure gradient is 7 or more. And those are typically patients with WHO group 2 who have a prolonged post-capillary pH and develop reactive PA vasoconstriction, then PA remodeling, leading to that precapillary component. The precapillary component is typically mild, meaning their PVR is in the range of 2 to 5, but the more prolonged and severe that postcapillary pH, the more the precapillary component may evolve into the severe range as well, over 5 Wood units. That combined pre-postcapillary pH may also be a combo. It may be a combination of WHO group 2 and WHO group 1. So the patient is an older patient with AFib and diastolic dysfunction and hypertension who also has a precapillary pulmonary arterial hypertension from pulmonary vascular disease unrelated to their left heart disease. Or they may have PE or lung disease.